Hello everyone, my name is Aida Karyashevich and my group consists of Adona Aslanai, Shannon Blizzard, Jessica Hay, and Jezuel Huego. We are group 17 and today we're going to be presenting on heart failure. The objectives of this presentations are to discuss heart failure, understand the etiology, risk factors, pathophysiology, and complications of the disease, discuss signs, symptoms, and diagnostic criteria, review the pharmacologic and alternative treatment approaches, and lastly, design an appropriate treatment plan for the patient case. MC is a 60-year-old white male who presents to the clinic for the management of his heart failure. He has been experiencing worsening of symptoms, including shortness of breath upon exertion. MC has past medical history of hypertension, hyperlipidemia, obesity, atrial fibrillation, COPD, and type 2 diabetes. He currently smokes an unknown amount per day, but does not drink, use alcohol, or use illicit drugs. MC has no known drug allergies. Currently, the patient is taking the following medications at home: albuterol 90 mcg inhaler, 1 puff 4 times a day as needed for shortness of breath, atorvastatin 20 mg tablets, 1 tablet once daily, Symbicort inhaler, 2 puffs twice a day, carvedilol 12.5 mg, 1 tablet twice a day, furosemide 40 mg, 1 tablet once daily, gabapentin 800 mg, 1 tablet twice daily, glipizide 2.5, 1 tablet twice a day, losartan 50 mg, 1 tablet once a day, metformin 1000 mg, 1 tablet twice a day, tiotropium 18 micrograms or Spiriva, inhale 1 capsule once daily, and warfarin 5 mg tablets, 1 tablet daily, except on Monday, Wednesday, and Fridays. The patient is to take half a tablet. So this slide indicates the patient current laboratory values and vitals. Most labs are within normal limits except those that are bolded, which include lipids, A1C level, blood pressure, and the patient weight, as this patient is obese. Based on today's presentation, the main problem for this patient is the heart failure, followed by hypertension, type 2 diabetes, hyperlipidemia, and lifestyle modifications.
So, what is heart failure? Heart failure is a progressive clinical syndrome that can result from any structural or functional changes that can impair the ability of the ventricle to fill with or eject blood. It may be caused by an abnormality in systolic function, diastolic function, or both. The leading causes of heart failure are coronary artery disease and hypertension. The primary manifestations of the syndrome are dyspnea, fatigue, and fluid retention. In response to a decrease in cardiac output, a number of compensatory responses are activated in an attempt to maintain adequate cardiac output, including activation of the sympathetic nervous system and the renin-angiotensin-aldosterone system, resulting in vasoconstriction, sodium and water retention, as well as ventricular hypertrophy and remodeling. These mechanisms are responsible for the symptoms of heart failure and can contribute to the progression of the disease. Heart failure is an epidemic public health problem in the United States. About 6 million Americans have heart failure, and 670,000 new cases are diagnosed each year. This is expected to increase in the future as the population ages. And a large majority of these patients with heart failure are elderly, who have multiple comorbid conditions that can influence morbidity and mortality. Heart failure can result from any disorder that affects the ability of the heart to contract and or relax. Common causes of heart failure for systolic dysfunction and diastolic dysfunction are provided on this slide. The American College of Cardiology Foundation and the American Heart Association Stages of Heart Failure and the New York Heart Association Functional Classification, listed on the slide, provide useful information in determining the presence and severity of heart failure. The stages of heart failure indicate the development and progression of the disease. The classes focus on exercise capacity and symptomatic status. Now for a review question. A patient with structural heart disease with prior or current symptoms of heart failure is at what stage? Stage A, Stage B, Stage C, or Stage D? The answer is Stage C. Since the stages were previously mentioned, let's briefly review the other ones. Stage A is defined as those at risk for heart failure but without structural heart disease or symptoms of heart failure. Stage B is when structural heart disease is present but without signs or symptoms. And Stage D is when there is refractory heart failure that requires specialized interventions.
Now we will go over the 2013 guidelines as well as the updates to the 2016 guidelines for heart failure. In the 2016 updates for heart failure, there were no changes made to the 2013 ACCF-AHA guidelines for the management of Stage A heart failure. Patients in Stage A should be placed on a diuretic, ACE inhibitor, ARB, and/or beta blocker in order to properly manage and control their hypertension. Patients in Stage A heart failure should also be appropriately managed for their cholesterol when appropriate. Obesity, diabetes, and tobacco use should also be properly managed, as this can worsen heart failure. The 2016 updated heart failure guidelines also did not make any recommendation changes for Stage B heart failure. According to the 2013 guidelines, in patients with history of a myocardial infarction or an acute coronary syndrome, and the patient has a reduced ejection fraction, the recommendation is that patients should be placed on an ACE inhibitor, or if the ACE inhibitor is not tolerable, an ARB. Patients should also be placed on a beta blocker, such as bisoprolol, carvedilol, and metoprolol succinate, and patients should also be placed on a statin. These three medications are used to reduce mortality and morbidity. If patients do not have a history of an MI or ACS, but they have structural cardiac abnormalities, patients should be placed on a diuretic, ACE inhibitor, ARB, and/or a beta blocker. In patients with Stage C heart failure, this is now where the new 2016 updated guidelines come into effect. According to the 2016 ACC-AHA HFSA updated guidelines, patients should now be placed on an ARNI, which is an angiotensin receptor neprilysin inhibitor. More information about this new medication will be mentioned on the next slide. However, it is used to further reduce morbidity and mortality in patients with Stage C heart failure. If patients are not placed on an ARNI, it is still recommended that patients be placed on an ACE inhibitor or an ARB for further reduction in morbidity and mortality. Patients should also be placed on a beta blocker, such as bisoprolol, carvedilol, and metoprolol succinate, and in patients with an ejection fraction of less than 35%, or if the patient has a history of acute MI or diabetes with an ejection fraction of 40%, it is recommended that the patient is placed on an aldosterone receptor antagonist. Also, if patients are self-described as African Americans with optimal therapy on an ACE inhibitor and a beta blocker, hydralazine and isosorbide dinitrate, also known as Bidil, should be added to therapy. Also, patients cannot be used an ACE inhibitor or an ARB due to drug intolerance or renal insufficiency, where it is contraindicated. Patients can also be placed on Bidil. These medications are used to reduce morbidity and mortality in patients with Stage C heart failure. Now, in those who are also in Stage C for reduction of morbidity, use of diuretics if there is evidence of fluid retention is also recommended. Another new update to the 2016 guidelines is the use of ivabradine, which again will be mentioned on another slide. However, it can be beneficial to reduce heart failure hospitalization in patients with a reduced ejection fraction. As mentioned on the previous slide, the new 2016 updated guidelines for the treatment and management of Stage C heart failure now recommends a new combination medication over an ACE and an ARB in order to reduce the morbidity and mortality. This new medication is called Entresto, which consists of a neprilysin inhibitor, sacubitril, and an angiotensin II receptor blocker, which is valsartan. Neprilysin itself degrades endogenous vasoactive peptides, which includes natriuretic peptide and bradykinin. Inhibition of neprilysin results in increased concentrations of these proteins in their activities, which results in vasodilation, natriuresis, and diuresis. This new combination medication, again, is to reduce the risk of morbidity and mortality in patients with chronic heart failure and in patients with reduced ejection fraction. Dosing is based off of whether they are treatment naive or depending on the previous ACE and ARB dose. In patients who are treatment naive, or if they were previously on a high-dose ACE or an ARB, patients should be initiated on the 49-51 milligram twice-daily dose. A high dose of an ACE inhibitor is defined as greater than 10 milligrams enalapril or equivalent, such as greater than 10 milligrams of lisinopril or 5 milligrams of bramipril. A high-dose ARB is considered anything greater than 160 milligrams of valsartan or equivalent, such as greater than 50 milligrams losartan or 10 milligrams olmesartan. If patients are on low-dose ACE inhibitor or ARB, so anything I just previously mentioned that is lower than those doses, patients should be started on the 24-26 milligram twice-daily dose. Once patients are initiated on the dose, it is expected to double the dose of Entresto after 2 to 4 weeks to the target maintenance dose of 97/103 milligram twice daily. Patients who are hypersensitive to any of the medications, such as sacubitril or valsartan, should not take this medication. Patients with a history of angioedema with ACE inhibitor use is actually also contraindicated. In the clinical trials, it was found that patients with using the ACE inhibitor was found to cause angioedema more over when using the ARB. Therefore, it is recommended that if patients were on an ACE inhibitor previously, or if they are switching from Entresto to an ACE inhibitor, it is recommended that patients wait 36 hours before starting Entresto or going back to the ACE inhibitor. And again, this is to reduce the angioedema risk. Also, patients who are taking ACE inhibitors should not take this medication. Or if patients are taking aliskiren in patients with diabetes, it is also contraindicated. Another medication that was recently added to the 2016 updated heart failure guidelines for stage C was ivabradine, or Korlynor, which is the brand name. Ivabradine is a hyperpolarization activated cyclic nucleotide gated channel blocker, which selectively inhibits cardiac pacemaker IF current in the SA node. It is indicated for patients with reduced ejection fraction in order to reduce hospitalization for heart failure. The caveat with this medication is that patients must be maximized on their beta blocker, and they must also have a resting heart rate of more than 70 beats per minute. Dosing for this medication starts at 5 milligrams twice daily. After 2 weeks, the medication can be adjusted by 2.5 milligrams twice daily in order to target a goal heart rate of 50 to 60 beats per minute. The maximum dose of ivabradine is 7.5 milligrams twice daily. And now for our learning pause point number 2. Which of the following has been shown to reduce morbidity and mortality in patients with heart failure? Is it A, ACE inhibitors, ARBs, and ARNIs? Is it B, beta blockers? C, aldosterone receptor antagonists? Or D, all of the above? The answer is D, all of the above. The one that does not contribute to mortality reduction is the diuretics and the new medication ivabradine. These medications are used to reduce the risk of morbidity only. For the learning pause point number 3, when switching from an ACE inhibitor to Entresto, what is the required time for the washout period? Is it A, 12 hours, B, 36 hours, C, 24 hours, or D, 48 hours? The answer is B, 36 hours. If you remember, in the clinical trials, it was found that patients who are on ACE inhibitors when switching to Entresto had more risk for angioedema. Therefore, it is recommended that in patients, when they are switched from an ACE inhibitor to Entresto, wait 36 hours before starting Entresto after they are discontinued on the ACE inhibitor. This also goes for if patients are switched from Entresto back to an ACE inhibitor as well.
Assessment and plan for MC. MC presents with shortness of breath and his ejection fraction is 35%. According to the ACCF and AHA guidelines, as we went over in the previous slides, MC is classified as having stage C heart failure. Our goal for this patient is to improve these symptoms and prevent their progression. As a plan, we want to discontinue the losartan and initiate Entresto at a dose 24/26 milligrams twice daily. Then we'll titrate to a goal of 97/103 milligrams twice daily, if tolerated by patient. We'll also initiate spironolactone 12.5 milligram tabs daily. As an alternative, we may double the dose of the losartan from 50 to 100 milligrams every day. According to the 2016 Heart Failure Guidelines update, Entresto is shown to benefit for patients in stage C heart failure. It should be started at a lower dose due to the fact that the patient was taking losartan, and also we're starting spironolactone due to the patient ejection fraction. With these changes, we'll monitor the potassium levels, serum creatinine, creatinine clearance, and blood pressure, and we'll also follow up with the patient 2 weeks in 2 weeks from now for titration of the Entresto. MC presents to the clinic with blood pressure of 145/92. This is not at goal per JNC 8 guidelines. The target blood pressure would be to maintain it below 140/90 since the patient is over 18 years old and then he also has diabetes. So the plan is to discontinue losartan and continue the heart failure regimen as mentioned in the previous slide. As an alternative, we could double the losartan from 50 to 100. The reason for this plan is because the patient's heart failure is a priority at this point, and once we have addressed that, the Entresto hopefully will also lower the blood pressure to the goal that we're trying to reach. We will evaluate this as we monitor the patient. The monitoring will be daily blood pressure, serum creatinine, creatinine clearance, and serum potassium levels. In 2 weeks from now, we will see the patient again to titrate up the Entresto. MC also doesn't have a controlled diabetes at the moment, and we say that because his A1C level is at 8.3%. Our goal is to decrease his A1C to below 7%, as stated in ADA 2016 guidelines. We also want to maintain the fasting blood glucose between 80 to 130 milligrams per deciliter and also maintain the postprandial glucose below 180 milligrams per deciliter. As a plan, we want to continue the glipizide and also initiate the Tanzium 30 milligrams subcutaneously once weekly. Also, we want to implement changes to the diet in order for the patient to achieve weight loss. As an alternative, we have thought of starting Invokana 100 milligrams, a tablet every day before the first meal. The reason why we went with this plan is because MC is an obese patient, and he would benefit from a glucose-lowering medication that not only treats his diabetes, but also gives him weight loss. And it has been shown that a continuous weight loss and a healthy weight loss also improves glycemic control per ADA 2016 guidelines. With this regimen, we want to monitor blood glucose, signs and symptoms of hypoglycemia, the A1C level, and then serum potassium and serum creatinine. We will follow up with the patient after discharge and also in 3 months after that in order to evaluate the A1C levels.
Problem number 4 on this patient's list is hyperlipidemia. The assessment is that the patient's calculated 10-year ASCVD risk score is 39.5%. Therefore, a high-intensity statin should be considered. He is currently taking atorvastatin 20 milligrams daily, which is considered a moderate intensity statin. His total cholesterol is 205 milligrams per deciliter. His triglycerides are at 266 milligrams per deciliter. His HDL is at 40 milligrams per deciliter, and his LDL is 111 milligrams per deciliter. The goals for this patient are to maintain lipid levels and reduce the risk of cardiovascular complications. Our plan for this patient is to increase atorvastatin to 80 milligrams by mouth daily and recommend lifestyle modifications. Our alternative would be to place him on rosuvastatin 20 milligrams by mouth every day. Our justification for this plan is that high-intensity statin is considered when the 10-year ASCVD risk is over or greater than or equal to 7.5% in those with diabetes and on an LDL between 70 and 189 milligrams per deciliter according to the ATP-IV guidelines. For monitoring, we're going to look for signs and symptoms of myopathy and also evaluate his lipid panel every 3 months. Our follow-up would be to obtain a lipid panel after 4 weeks to assess the effectiveness of the therapy that we've chosen. We'll adjust the therapy if needed based off of results, and once stable, we're going to monitor the patient every 3 to 12 months. Along with our other 4 problems, the patient also needs some lifestyle modifications. Our assessment is that the patient is obese and has comorbidities such as hypertension, dyslipidemia, type 2 diabetes, and obesity, which are all contributing to his CHF exacerbations. Our goals for this patient are to modify aspects of his lifestyle, such as smoking cessation and weight loss, to allow for a better quality of life and maintain baseline health status. Our plan would be to include smoking cessation counseling, which would also include options for quitting, such as nicotine patches and gum and lozenges, and also weight loss through a diet and exercise plan. We would want him to exercise at least 150 minutes per week, and we would also recommend that he follow the DASH diet, which would be a lowering of salt in his diet. Our alternative would be that if the counseling is met with resistance, we can offer pamphlets and assistance when the patient is ready to achieve these goals. Justification would be that through the use of lifestyle modifications, the patient will be able to maintain baseline health and avoid possible future CHF exacerbations. For monitoring, we will have the patient do a diet and exercise log and smoking cessation counseling check-ins, which we can assess at each follow-up visit. Our first follow-up visit would be in the clinic in 1 month to assess the plan and the patient logs and whether the goals are being reached. In conclusion, it has been found that uncontrolled hypertension and coronary disease may lead to heart failure, which significantly impairs the quality of life for patients. Any disorder that affects systolic and diastolic function of the heart may lead to heart failure, which is more commonly seen in the elderly, such as our patient. Patients with heart failure are treated based on the disease classification according to ACCF, AHA, and NYHA. The latest update to the ACC, AHA, HFSA guidelines as of 2016 recommend for patients classified as NYHA Class 2 or 3 who tolerate an ACE inhibitor or ARB use an ARNI to further reduce morbidity and mortality. Here are our references that can be found throughout the PowerPoint. Thank you, and if you have any questions, please feel free to leave them on the discussion board and we will answer them for you.